Hello, everyone. My name is Ahmed. I'm a third-year pathology resident, and today I'm going to be talking about acute myeloid leukemia with NPM1 mutation. This is an acute myeloid leukemia that is characterized by the presence of a somatic mutation, including the nucleophosmin 1 gene. It's a very common leukemia that accounts for about 1/3 of adult AML cases. It's prevalent in middle-aged patients and mostly in women. Clinically, most patients present with anemia and thrombocytopenia. However, leukocytosis is very common. Morphologically, the blasts have a specific morphology that we're going to look at in this case of a 40-year-old female who presented with fatigue and shortness of breath and was found to have circulating blasts in the peripheral blood. So let's have a look. So now looking at this peripheral blood for this patient, it looks to me like the patient is anemic with these empty spaces between the red blood cells. Some cells are atypical and are large, like this cell here, and this cell here. So let's go high power to see what's happening. So as you can see, I do see these two cells here, this one and this one, with large nuclei, high NC ratio, and scant amount of cytoplasm. And this one here looks like a fish mouth or it looks like a cup. So this is a blast with cup-like morphology or fish mouth-like morphology. So let's go around and see if we can see more blasts in the peripheral blood of this patient. Here, this one here. In the center of the field, let me get in focus. And this blast here has this cup-like morphology as well. Let's go around. Here, this one here. Is a is then another blast with this cup-like morphology. So we do see a lot of circulating blasts. Here, this one is a blast as well. This one is a blast. These here are blasts, these three cells. And these two cells here are blasts with a cup-like morphology as well. So I do see frequent circulating blasts in the peripheral blood of this patient. These blasts are characterized by this cup-like morphology, and the presence of this morphology in over 10% of blasts in the peripheral blood or bone marrow is highly specific for acute myeloid leukemia with NPM1 mutation. Now let's have a look at the bone marrow aspirate smear. There we go, high power. And on this magnification, you can appreciate that we do have myeloid predominance. Most of the cells in this field here are myeloid cells. And then going here, let me go high power. And these cells here, like this one here, this one here, this one here, this one here, and this one here, all of these are blasts. So we do see a lot of blasts in the bone marrow aspirate smear of this patient, and we ended up counting 82% blasts in the bone marrow aspirate smear. Now let me show you the direct smear. to have a better look at the morphology of these blasts. You can see here, these are more blasts in the bone marrow of this patient. Now, let me show you the bone marrow core biopsy. This is a 40-year-old female. So I expect the marrow cellularity to be about 60%. And as you can see here from this low power, the cellularity is over 90% or maybe over 80%. This marrow is markedly hypercellular. So let's go high power. Let me add some oil. Let me go even higher power. And what I see here in this field is sheets of large atypical cells. These cells have open chromatin, like this one here, this one here. We describe this chromatin as open chromatin. It's as if you can see through it. I do see prominent nucleoli, like here, 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 and here. So many prominent nucleoli. I do see these cells with irregular nuclear contours, high nuclear cytoplasmic ratio, and they do have this eosinophilic cytoplasm. And these immature cells, probably most of these cells are blasts. Going around. Like this area here has the same morphology. This area here has the same morphology. And this area here has the same morphology. So we do have a markedly hypercellular marrow with predominance of blasts. Now, looking at the histopathology here, the blast morphology is variable in this entity. However, myelomonocytic differentiation is common, and blasts with cup-like morphology are commonly seen, and the identification of over 10% of blasts with this morphology is highly specific for this acute myeloid leukemia. As for multilinear dysplasia, it can be seen in about 20 to 25% of the cases. As for the immunophenotype, most cases are CD117, CD33, CD123 positive. CD34 is interestingly negative in about 80% of the cases. And we do have three immunophenotypic categories that most cases fall under. The first category is cases with predominance of immature myeloid blasts that can be either CD34 positive or negative, and they are positive for CD117 and HLA-DR. The second category is cases of acute promyelocytic leukemia-like features, and these are characterized by CD34 and HLA-DR negativity, as well as CD117 and MPO positivity, just an acute promyelocytic leukemia. And that's why not morphologically, that's why on flow cytometry, if you have a CD34 negative, HLA-DR negative population, you should not jump to make a diagnosis of acute promyelocytic leukemia with PML RARA fusion. First of all, because it's a morphologic diagnosis, not a diagnosis that you make on flow cytometry. And secondly, because there are other leukemias like acute myeloid leukemia with NPM1 mutation that can have a similar immunophenotype. The third category is cases that are characterized by predominance of myelomonocytic or monocytic differentiation, showing monocytic markers like CD14, CD36, and CD64. And by immunohistochemistry, you can actually detect cytoplasmic NPM1. So NPM1 is normally expressed in the nucleus of the cells. However, if you see these atypical cells or blasts that have cytoplasmic NPM1 staining by immunohistochemistry, it's considered to be a surrogate marker of NPM1 mutation. Now, let me show you the flow cytometric findings in our patient. And as you can see here, we have this very large dim CD45 population. This population is positive for CD33, CD117, negative for CD56. HLA-DR is negative. CD3, which is a T-cell lymphoid marker, is negative. CD19, which is a B-cell lymphoid marker, is negative. CD33 is positive in this population. And CD34, as you can see here, some of these cells are negative and some of these cells are positive. So you can call that dim CD34. And some people would call it partial. CD117 is positive. HLA-DR is positive. And CD13 is positive. CD123 is positive in the majority of cases, and this is useful because there's targeted therapy against CD123. And as for our monocytic tube, CD11b is negative in our blast population. CD16 is negative. CD14, which is the most sensitive or most specific monocyte marker, is negative as well. So we don't have any monocyte differentiation by flow cytometry. Now, let me show you flow cytometric findings of a different patient. This patient here, as you can see, has this large dim CD45 population, and this population is completely negative for CD34. T-cell lymphoid markers, including CD2, CD3, CD5, and CD7 are negative. CD19 and CD20, which are B-cell lymphoid markers, are negative. And myeloid markers, including CD13, CD33, and CD117 are positive. And CD123 is positive. The monocytic tube, as you can see, CD11b, CD16, and CD14 are negative, so it doesn't have expression of the monocytic markers. And lastly here, MPO is positive, and TDT and CD79A, which are lymphoid markers, are negative. Now, as for the molecular findings, NPM1 mutations typically involve exon 12. Most patients show normal karyotype. However, additional chromosomal gains can be seen in some patients. To make a diagnosis, you need to identify a myeloid neoplasm with increased blasts in the peripheral blood or the bone marrow, and the blasts may be less than 20%. You need to identify NPM1 mutation in a patient with no history of exposure to cytotoxic therapy. A desirable criteria would be detection of cytoplasmic NPM1 expression by immunohistochemistry. And as for the prognosis for these patients, is generally favorable. However, it can be influenced by other co-occurring mutations. For example, normal karyotype with no FLT3 ITD mutation, or with FLT3 ITD mutation with low mutant allele ratio is considered favorable risk. The presence of NPM1 with NRAS or NPM1 with FLT3 TKD mutation is favorable prognosis as well. If you have a FLT3 ITD mutation with a high mutant allele ratio, this is considered intermediate risk. And if you have a combination of NPM1 with FLT3 ITD with DNMT3A mutation, that's considered poor prognosis. And the presence of a concomitant NPM1 as well as WT1 mutation is considered poor prognosis as well. So generally, it's favorable prognosis. However, it can be influenced by the additional mutations that you can see in your case. This is the end of this video, and see you next time.